Hi, good morning, good afternoon, good evening, everybody. Welcome to this webinar on the Equity Strategic Planning Guide on creating equitable access to high-quality family planning information and services. I'm Peter Stein, I'm from WHO. I will be the moderator today. Next slide, please. So, as you can see, we have a full agenda for today with several well-known speakers. We've started a little bit late, and to have the things more flowing, I'm going to ask the people to introduce themselves quickly at the beginning so that we don't go from one computer to the other people. We will first have the USAID remarks and then the other. Just before we begin, some reminders. This webinar will be recorded and it will be available later on. Please visit the website of the fphightimpactpractices.org. You will find that quite a few times still during the webinar. You can submit your questions anytime. We will collate it, and then please also, if you want to have it addressed to a specific person, just mention to whom you want it. Well, that will make it easier for us. And then there's the download of the handouts that you can do now as well. Next slide, please. So just a reminder about what the high impact practices, or shortly as we call it, HIPS, is. It's evidence-based practices, family planning practices specifically, vetted by experts against specific criteria, and then documented in an easy-to-use format that will be shown later on during the presentation again. Next slide, please. There are several high-impact practice categories, and they are grouped into three primary categories. First of all, the enabling environment. Then we have the service delivery high impact practices. And then the third category is the social and behavior change practices. And then there are two enhancements as well. Next slide, please. So today we have the webinar, as I mentioned, on Equity Strategic Planning Guide. Creating equitable access to high quality family planning information and services. Next slide, please. We have the four panelists today here. And as I mentioned, they will introduce themselves just before they do their presentation. Next slide, please. Over to the first speaker, Rubina. Can you please introduce yourself and do your presentation? Thank you.
Thank you very much. Can you hear me?
Thank you.
Okay, can you hear me?
Yes.
Perfectly clear, thank you.
Okay, I'm Robina Sempewa. I work with USAID Uganda, and I am the Deputy Family Health Team Leader. And the Family Health Team oversees family planning, maternal child health, the WASH, and nutrition portfolio. I'm glad to be here on this webinar. Thank you very much, Petros, and hello everyone. I am pleased to join you today on behalf of USAID and want to start by thanking our hosts for convening this important discussion on creating equitable access to high-quality family planning information and services. As the strategic planning guide says, equity in family planning does not mean that all groups use contraception or specific methods of contraception at the same rates. Rather, equity is realized when all individuals have access to high-quality reproductive health information and contraceptive services, including choice of methods and availability of those methods that reflect their values and preferences and the context in which they live, regardless of age, sex, disability, race, ethnicity, origin, religion, economic status, or other factors. This is fundamental to USAID's family planning and reproductive health policy on voluntarism and informed choice. As the world's largest family planning bilateral donor, USAID is committed to ensuring that women and couples in developing countries have access to voluntary family planning services and fertility awareness and are free to make informed decisions about their reproductive lives. However, millions of women and couples still face barriers to reaching their reproductive desires, and countries face challenges in providing universal access to contraceptive services. This timely strategic planning guide provides step-by-step instructions that USAID missions, their country counterparts, and implementing partners can use to create and measure equitable family planning and reproductive health programs. USAID in Uganda, in collaboration with the Ministry of Health and various implementing partners, has a history of using high-impact practices products. Most recently, in the Government of Uganda Revised Family Planning Cost Implementation Plan, covering the period 2020 to 2025, there is a deliberate effort to use and scale up the various family planning high-impact practices by the different stakeholders. We expect this strategic planning guide could be used by USAID, the Ministry of Health, and many local stakeholders in Uganda and other parts of the country to identify inequities in family planning and design and measure interventions to reduce them. Finally, it is worth noting that the strategic planning guide is complemented by other USAID strategic documents that include a focus on equity, including USAID's cross-cutting vision for health system strengthening. The vision for health system strengthening recognizes that an equitable health system affords every individual a fair opportunity to attain their highest level of health, regardless of social or demographic factors, with particular emphasis on underserved, socially excluded, and vulnerable populations. The vision articulates how USAID focuses health systems equity efforts on local contextual needs by identifying and addressing related health and social determinants, as well as health system performance limitations that impact equity. This work provides a foundation for implementation of the steps in the Family Planning Equity Strategic Planning Guide. Thank you for your time today. Over to you, Petros.
Thank you very much for that really appropriate introduction, and then we will move on directly to the next speaker. Sarah, please.
Okay, good morning, good afternoon, everyone. I'm just going to turn on my camera to say hello, and to help with the bandwidth, I'm just going to keep my webcam off. So next slide, please. So I represent the High Impact Practices Technical Advisory Group, and I work with Palladium as a Senior Technical Advisor for Family Planning, primarily on the project Health Policy Plus. Next, please. So Robina gave us a lot of good background, and I'm going to dive in a little bit to the equity the equity discussion paper that was published and for which you can download under the handouts tab. And to start us off, I'd like to give you a few thoughts about equity and development. So the development community has spoken about the importance of equity since the 1940s, and the FP community has purposely sought to improve equity and access to contraceptives and FP services for over 50 years. In the last 20 years in particular, eliminating inequity has been a focus of the Millennium Development Goals, the SDGs, and universal health coverage, all with the goal of leaving no one behind. In the FP arena, equity is a guiding principle of the FP High Impact Practices Partnership and a key element of rights-based services under the FP 2030 initiative. The HIP TAG, Technical Advisor Group, has had questions about how we know if FP programs are equitable as we review the various briefs before they're published. We realized we didn't have a standard definition of equity for the HIP briefs, and we didn't know for sure if the claims made about reaching equity were correct. Next slide, please. So we started this discussion in 2015, asking questions such as, what are appropriate measures for making claims of increasing equity? How do we know that we are actually reaching the underserved and most disadvantaged? How do we measure equity? And exactly how is equity defined in our community? In 2018, we were able to conduct a literature review and produced a discussion paper. Karen Hardy and Erica Hofleting were lead authors. We sought to answer the 4 questions you see on the screen, and we hope that this would provide greater insight for the TAG as we evaluated evidence presented in the HIP briefs. Next slide, please. So before recommending a standard definition, we wanted to be clear on how we understood equity. So we agree that we aim to reduce and eliminate inequities in health. And as you see, pursuing health equity means striving for the highest possible standard of health for all people and giving special attention to the needs of those with at greatest risk of poor health based on social conditions. This last point on the slide from Whitehead is particularly important. When the conditions are systematic, socially produced, meaning there are no inherent biological reasons for the differences, and unfair, then there is an inequity. Next slide, please. As the TAG, we agreed that the WHO definition reflects these 3 key elements from Whitehead. These concepts show up here in the WHO definition in the first line, where we see that equity is the absence of avoidable, unnecessary, and unjust differences. Another important element in this definition for the HIP TAG is that it references groups defined by social, economic, demographic, geographic, or other characteristics. So often there is a focus only on the economic differences, which is very limiting and may not reveal the full nature of inequities in FP programs. Next slide, please. The TAG also included references to this definition, which is more specific to FP and comes from FP 2020, or now FP 2030. It also includes additional concepts relating to the delivery of FP services and information, namely availability, accessibility, quality, and acceptability. Importantly, this definition specifically brings in the concept of rights-based family planning, as the right to health is based on this and includes family planning information, services, and supplies. Next slide, please. So we looked at different frameworks to help us understand equity in FP programs. There are various frameworks we considered to help us see if we could define, how we could define equity, identify the different dimensions of equity, and help us operationalize how we address equity in our FP programs. So the HIP TAG found that the WHO Priority Public Health Conditions Analytical Framework was good to use for the HIPs. It's developed for work on social determinants of health, and importantly, it is important to holistically think about our FP programs and consider all the different influences leading to inequities in FP programs. For FP programs, this framework can help us examine what the social determinants of the particular inequities are, where there are priority points for interventions, what adverse effects might occur from said interventions, and what has already been tried. You can think of this process as a little bit of the why approach to designing programs, and you'll hear more about diagnosing inequities from the next speakers. Next slide, please. So in the literature review, which is the basis of the discussion paper, we found some interesting findings. We discovered that our FP community is not great at documenting equity aspects in our programs. The ways in which we've examined or identified inequities has some limitations, including that we focus heavily on economic interventions, as I mentioned, rather than considering broader definitions, such as the range of statuses and characteristics which people vary, where they live, whether or not they're married, etc. We also found that programs were focusing mostly on contraceptive use, but there are other outcome measures we could use, and we'll hear more about this later. As Robina mentioned, it's important to acknowledge that FP is a little bit different than other health areas. We don't necessarily find that all groups are using contraceptive at equal rates. If we found that, it could mean that there was a violation of voluntary and informed choice, which is very important for FP. So unlike maternal health, for example, where we would want all women delivering a baby to have a skilled birth attendant present, that's not the same for FP. Also, equity takes time to improve, and the outcomes need to be considering both supply and demand side of our programs. Next slide, please. So what we learned through this process led us, a group of us, as you can see here on the screen, to publish just last month a commentary in the WHO Bulletin to provoke a broader conversation about how we really are measuring equity. The link is included on the slide and you can look it up later. And with that, I'd like to pass it on to Jill, who's going to give us more detail about the strategic planning guide itself. So thank you for giving me this opportunity.
Jill, we cannot hear you.
Sorry, I did the camera and forgot the mute. Sorry about that. Hi, I'm Jill Peterson with FHI 360 and the R4S project. And I'm going to go, as Sarah said, into the guide itself. So if you want to, thank you. Okay, next slide, please. So quickly before we get into the guide, and we've talked about this a little bit already, but for people who are not quite so familiar with the difference between the HIP briefs and the strategic planning guide, I'll spend just a minute talking about this. So HIP briefs, as Petra set up earlier, define a practice and summarize evidence of the impact and experiential learning from implementing that practice. And as he mentioned, they're divided into service delivery, enabling environment, social and behavior change, and then there are a couple of HIP enhancements. Next slide. An example of one, because I think it's a little bit easier when we can look at one more closely, are community health workers, for example. And so if you go to the HIP website and you look at the briefs, you'll see something like this one talking about community health workers. You can download a nice version of it, but you can also click through the options I've put on the right-hand side of the screen here. So a description of the practice, the background, what is the evidence, how to do it, tips for implementation, priority research questions, and then indicators to track implementation of the high impact practice itself. So again, those are focused on a practice, and then the guides themselves, strategic planning guides, outline a process, and the process is intended to identify the most effective and efficient investments to address the challenge or address the needs of a population group. And so there are now 5 of them available. One focused on adolescents, one looking at engaging men and boys in family planning in humanitarian setting, and one on task sharing. And then this one that we're focused on today is the 5th in the series, creating the equitable access. So next, let's take a look at on the next slide about why equity in family planning is important. So equity in family planning improves access among all people, regardless of the social determinants of health. And I'll talk about those a little bit more in just a minute. And also considering inequities helps to reach the hardest to reach or previously overlooked members of a community or of a population. Next slide. The Strategic Planning Guide also goes into these concepts of equality, equity, and justice, and this is really in the setup of the Strategic Planning Guide. So as you see in the figure here on the right-hand side of the screen, we have people of varying sizes representing various populations standing on boxes to watch a football game or a match, depending on where you're from. The Strategic Planning Guide I wanted to say that the different sized figures are not intended to suggest differences in value, but rather to show the assets of different groups are not all the same. And the fences and the boxes represent, the fence represents the barriers, and the boxes represent support potentially given through the existing system. So as you see, providing everyone equal support to see over the fence does not result in the same outcome for all spectators, as we see in the first panel there. Equity recognizes that people may require different resources to overcome barriers in the existing system, and you see that in the middle panel. And then finally, justice takes an additional step to acknowledge and address the barriers and directly seeks to remove them. So there you see we've removed support because we have been able to remove the fence or the barrier. Next slide. So then we go through a series of 4 steps in the Strategic Planning Guide, again outlining the process. And the first here is determining whose needs are not being met. So I mentioned earlier the social determinants of health, or we can call them here in Table 1, categories of characteristics potentially related to inequitable family planning outcomes. And these are things I think we're familiar with. As Sarah mentioned, there's been a lot of focus on economic characteristics, but we can also consider social and environmental. So social characteristics would include age, race, ethnicity, sexual orientation, religion, language, others listed there. And environmental could consider geographic location, so urban and rural or distance from a health service, and perhaps a humanitarian setting. So as we are trying to determine if we have inequities or not, there are certain questions we want to ask ourselves, and then we have given in the Strategic Planning Guide some suggested measures to take a closer look and determine if you have differences by groups. So if you're asking yourself, are those who want to delay space or limit their next pregnancy using contraception, you could look at demands satisfied or reasons for non-use. If you're asking, do people in the group lack contraceptive autonomy, you could look at unwanted or mistimed pregnancies. And if you're asking, are people in this group at a higher risk of adverse events from a pregnancy, including maternal mortality, you could consider a measure looking at adolescent pregnancy, short birth spacing, or unsafe abortions. So this is really getting at that first step in the panel. Are there differences? Do you see differences in any of these measures by the different groups that you're looking at? And then if we go to the next slide, step 2 then is to figure out, is it an inequity? And in order to do that, we need to first determine what are the barriers that individuals from this population group face in accessing high-quality family planning information and services. So we have included in the guide itself links to some helpful tools for defining barriers, including how to conduct a root cause analysis, a practical guide to conducting a barrier analysis, a link looking at the social ecological model, and then the social norms exploration tool. And within that, then, we can ask ourselves again 4 questions. Do the barriers lead to disproportionate family planning outcomes for the population group relative to the reference group? Are the barriers amenable to effective interventions? Are the barriers undesirable? And are current interventions to relieve or reduce this condition less available to the disadvantaged population groups? And Gillespie and colleagues wrote up these questions and said, if you come up with a yes to all 4 of these, you have an inequity. So we've moved then to the second panel of that figure that we were first looking at and determined it's not just inequality, there's actually an inequity going on. So then step 3, if we go to the next slide, is really what do we do about it? How can we make the family planning program more responsive to the values and preferences of all people? And so in the guide, we talk about conducting a landscape analysis is one thing we can do. So find out what's already going on. Is anybody else already working on this issue? Who's working on it? What are they doing? What have they done in the past? What's been successful? What's maybe not been successful? Find out what is really going on out there in the landscape. We can do an asset-based analysis, so brainstorm local solutions and improve upon what's already working. So get out and talk to people, find out what's been successful maybe in other places, other situations, other health service areas perhaps. Talk to people out in the community, make sure you get local solutions involved in thinking about it. And you can, of course, consult the HIPs. So there are these high impact practices that are evidence-based that may help you solve the inequities that you're looking at. So for example, would deploying a community health worker program help you reach more people if that's the inequity that you're dealing with, for example? Okay, and then step 4 in the last slide, of course, we need to monitor these things as we go. So we've put together some effective monitoring considerations I've summarized here. The first recommendation can be done with existing data in most cases, and that is to look at your data and disaggregate it by some of those factors that we talked about, age, region, whatever you have access to. And we have also provided in the guide links to nice tools to help you get at this data. So this is probably what you've done in step 1, and then you want to make sure that you're monitoring it throughout your process here. We also want to look at potential unintended outcomes of increased family planning information and use. So perhaps gender-based violence is something you want to keep an eye on, or anything else that you can identify that may be an unintended outcome, because of course we want to mitigate those as much as possible, avoid and mitigate, I should say. We also want to make sure that information from clients is collected and analyzed to determine if the care received was free from stigma, discrimination, and bias. So we don't just want to, check the box, yep, we did it, it's done. It has to meet a certain quality standard as well. And then finally, quality improvement strategies can be used to address any identified issues that you come up with as you're doing your monitoring. So those are the 4 steps that we go through in the strategic planning guide. And I think we're next going to hear about implementation in Uganda. Thank you.
Thank you very much. And then we will, the last talk in this session will be the Dina from the Ministry of Health in Uganda. Over to you. Thank you. Dina, are you able to connect?
Okay, I've been unmuted. Hi, everyone. Good morning, good evening. I'm Dina from the Ministry of Health Uganda, and I'm the Assistant Commissioner for Adolescent and School Health. I sit on the Family Planning Working Committees, and still I work on the Equity Steering Committee that we've just had for the last 4 months, and I'm happy to share with you our experience as a country. Can we go to the next slide, please? So like I've said, I'm going to share Uganda's journey, which is not so long, but I'm glad that we've followed through the different processes of generating the SPGs and all this, and we will share our response and our perspectives as a country so far. Next slide, please. So the background really is that the Ministry of Health has prioritized addressing inequities in family planning, both at policy but also at program levels. And this is really to ensure that we meet our universal healthcare coverage, but also pointing towards reaching the SDG 3. And we have looked at having key strategies, especially in the family planning costed implementation plan 2, which has run from 2021 to 2025. And we've also ensured that these inequity and equity gaps are really covered in the family planning 2030 commitment that the country just concluded and launched. We are up to looking at promoting interventions to reduce inequities in family planning service provision. And we are mainly doing this as government, but also through the different implementing partners that you are working with at the Ministry of Health and also at the subnational levels. The challenge has been, however, that we've had limited evidence on the impact of some of these interventions in reducing inequities as an outcome. And can we go to the next slide? So our experience, we initially did an equity analysis that was conducted by partners, including the Research for Scalable Solutions at the Makerere University School of Public Health, which is one of our key partners in this whole research agenda, and PMA. And after this equity analysis was done, we got some bit of integrated evidence into FP CIP 2020-25, and also we have some evidence in the Family Planning 2030 commitments as a result of the research agenda, but also among other evidences that we have been working on as a country. Like we've already noted, we have various evidences from PMA, but also other researches that have been done in the country. So the Ministry of Health collaborated with key partners to initiate an equity steering committee, which in this presentation I'll abbreviate as ESC. And just to mention that this Equity Steering Committee is a subcommittee of the bigger Family Planning Technical Working Group, which is also under one of the key reporting channels for Ministry of Health. So the Family Planning Committee again would report to the bigger maternal and child health cluster, which would look at the bigger areas of health, but focusing, on issues around family planning. Next slide, please. So this particular slide just highlights for us the various areas of inequity, and the previous speaker kind of hinted at these. And for this particular one, we have defined the various areas at a 50% point with the desired outcome. But I also just want to note that it could be different if you used another indication. For example, if we look at definition at 10%, at less than 10%, then it may change a bit for some dimensions such as access and dimensions such as family planning messages. So please note that depending on which particular definition you're using, the slide changes. So for this particular one, we will just focus on the inequity areas, which are shaded on this slide as green. And then for those where we feel there is some bit of equity, we have them as gray, as the gray areas. So I'll quickly point to the wealth dimension. And in this slide, we see that for the people in the low wealth quantiles, the demand satisfied is really, really less than 50%. Another dimension that I would also look at is the education one. And we see that for those that have never gotten any kind of education, again, there is lots of inequities regarding their demand satisfied for family planning. And if we go lower down the slide, we can see that for the region, So for the region, for the northern part of Uganda, we see that people in this region, again, their demand satisfied is less than 50% compared to other areas of the country. And of course, there are lots of reasons as to why this is happening. But lastly, for the age dimension, we also see that the adolescents, and the adolescents mainly, the 15 to 17 and 18 to 19, we see that again their demand satisfied is less than 50%. So for the next equity dimension, we look at teenage pregnancy. We see that there is some bit of equity across the board, the different dimensions. Same for but then for access to family planning, we are seeing that there is a general inequity across all the different dimensions of equity. But like I had mentioned in the previous, like I have mentioned on this slide, depending on what definition you're really looking at, if we compared with a slide of 10%, which I should have also compared with, we see that the dimensions would really change for especially teenage pregnancy and also access to family planning care. I probably will share this, but I know that for teenage pregnancy, you would see there are lots of areas with inequities, especially for teenage pregnancy, if we brought down our percentage points to 10%. Next slide, please. So why then, what is the purpose of the Family Planning Equity Steering Committee? Like I've said, the steering committee really is to provide guidance on the development of definitions for the country and also measurements and tracking of the inequities that can inform potential strategies to address the various inequities. I'm glad that the speaker before me spoke about this, and I will not explain it any better than her, so we will move to the next slide. So our steering committee has a combination of both government and non-governmental organizations, but together with implementing partners. And it's a body made up of around 24 members, and the Ministry of Health is the chair to this equity steering committee, but it's co-chaired by UNFPA, which is one of our main donors. And we see strategically there is the academia, which is the secretariat, and for purposes of also involving the research agenda into our actions. We also have lots of civil society being represented, the faith-based young people, just to mention a few. But we ensured that the refugees, because we know that in our country, one of the geographical issues that we face is those around people living in refugees. So we thought that this was going to be one of the areas that we needed to look at. So this steering committee has been formed since July, which is around 4 months now, and we will move to the next slide to see what we've done so far. So, objectives of the Equity Steering Committee are mainly four, and one, it's a lead advocacy body for equity in family planning programming in Uganda, and then secondly, supporting the mainstreaming of equity definitions and measurements for family planning in the health sector, strategic documents. Then the objective number 3 is to identify research and implementation science priorities for equity in family planning in Uganda. And lastly, is to provide guidance and support to the operationalization of the measurement and monitoring framework for equity in family planning programming. So maybe just to clarify again on this, as a country, we agreed that there could be various areas of health where there is inequity, but strategically we said that we will specifically look at family planning for the start. And once we have gotten very good lessons around how it's going for family planning, then we can expand to other areas of health. So as we work on family planning, we know that, and we are cognizant that there are other areas of health which we can probably learn from the Family Planning Equity Steering Committee and scale up to other areas of health, but also other sections of government. Next slide, please. So this is our roadmap as the steering committee. And I want to say that we have already surpassed some of these. The concept has been done, and during the conception, we got evidence from the Research for Scalable Solutions project, which is run by the Makerere School of Public Health, and a whole country consultation was done. So from this consultative activity, that is how now we went to understand what the country is going to do, and developed a concept note after the research and the country consultation was done. And there was a validation of the concept by the Ministry of Health core team, the 24 people that have called, that I've spoken to before, but also the bigger family planning technical working group to validate the research findings that the School of Public Health had done. And once this was done, then there was a launch in which the concept was presented to the steering committee for more inputs and validation. And of course, the way it is now, it's as a result of consultation, not only from the small team of people, but everyone that attended the launch and the different stakeholders that we had, including school, someone from Ministry of Education and other sectors outside health. So once the launch was made, then we went into what are we measuring as a country. One, we developed consensus on the definition of equity for family planning in Uganda. And secondly, we also developed a measurement and monitoring framework for equity for family planning in Uganda, looking at the definition, the indicators, and data resources. And of course, these have really been based from the concept and the consultation, but also what is really key in our country. As we've seen some regions like the north, like we've seen, have different issues compared to areas in the central and east, maybe in the west. So that is why we are really saying for Uganda. And then the next phase would be in our accountability, and we would, one, identify research and implementation priorities to address the inequity in family planning programming. Secondly, we will mainstream the equity definitions and measurements into health strategic documents. And of course, we've somehow highlighted some documents in which we are doing this already. And number three, we will provide guidance and support on the operationalization of the monitoring and measurement framework for equity and family planning. And then advocacy will continue. And one of the key roles of the steering committee, as we have had, is to provide a platform for continuous dissemination of the findings from the performance, accountability and monitoring activities to family planning stakeholders. And secondly, we will convene quarterly meetings to review and discuss progress. But this is not the end of this roadmap. As you can see, from advocacy, again, we come back to measurement. So it's kind of a cycle, but we failed to show that this is circular. But again, we keep coming back, hearing from the advocacy points and the learning. So it's continuous journey. Next slide, please. So what have we learned from the equity and the strategic planning guide? And these really, of course, they're the ones that inform the Uganda roadmap. We've learned that identifying inequities in family planning and interventions can really, we can have them to go through these steps. So one, and previous speaker spoke to the various steps, but I'll quickly run through them, but we've had someone really elaborately speaking about the steps. One is to determine the needs that are not being met. Two, the barriers. Three, make family planning programming more responsive to the values and preferences of all people. And lastly, monitor implementation. I've rushed through this one because I know someone has already spoken about this already. Next slide. So equity measurement. We will, one, develop consensus on the definition of equity family planning in Uganda. And then two, develop measurement and monitoring framework for equity for family planning in Uganda with clearly defined indicators across the economic category, looking at the wealth and occupation for different people. Then the social dynamics, really looking at age, religion, education, marital status, disability, refugee status nationally, and also the gender norms in the different areas. And yes, we will look at the geographical distribution of the populations, looking at where they are staying, urban versus rural, and then the distance from the health facilities, and yes, the humanitarian settings I have mentioned already. Can we move on, please? So for accountability, one, mainstreaming the equity definitions and measurements into the health sector strategic documents. We have already done some for the various health sector strategic documents. And then we will support operationalizing of the monitoring and measurement framework using various data sources and analysis to identify who is left behind and why. So it's work in progress, and then we would refine research. So for this particular one, it just goes to show us that we need a comprehensive sexual reproductive health programming, and it goes through the continuum of care from childhood, round until we age. It has to be comprehensive and focusing on the continuum of care. Next slide, please. So for advocacy, what have we already done? Like we have mentioned, it's a platform for continuous dissemination to inform policy and programming. And like we have, as mentioned before, the advocacy has been ongoing, and we've already informed some documentation, such as the Family Planning 2030 commitments. There are lots of equity notes that we've made there, and this has already been launched on 3rd November. And also we've informed the National Population Policy 2021, which will be launched, I think, the day after tomorrow. And then we have informed the FPCIP too, and this will be launched before December. So advocacy also would ensure that we make family planning programming more responsive to the needs and preferences of all population subgroups and monitor implementation. Thank you very much for listening to me. This should be the end of my presentation. Thank you all.
So thank you so very much to everybody. Would really like to thank Rubina, who started off with the USAID remarks, then Sarah, who set the stage for us with the equity discussion paper, Jill going through the planning guide overview and the tool overview, and then Dina coming with this practical application and learning from that. So we have a few questions here. And the first question will go to Sarah Stratton, and that is the question: there is also behavior-focused political economic analysis. What are your thoughts on that, Sarah?
Okay, Petrus, could you repeat the question? What are the behavioral focus?
So sorry, I'm struggling here with my connection as well, so I'll talk a little bit slower. There is also behavior-focused political economic analysis. What are your thoughts on that?
Oh. Okay, sure. So I think when we, as a HIP tag, when we were looking at the various issues, we relied on the literature that was available, and actually there was not a whole lot. There were not a whole lot of papers that were particularly addressing equity in family planning programs. That's one of the reasons I made the comment that our community needs to do more, and I'm encouraged to see that Uganda has a particular strategy around research and implementation science. There are other ways of looking at inequities, and political economy and economic analyses could reveal some. There are a lot of behavioral issues related to inequities, and that's one of the reasons we encourage examining other areas, characteristics besides just wealth or wealth-focused ones. So certainly the whole social set of characteristics that also include social norms, gender norms would be important to consider. So there are definitely ways to use those two theories to diagnose and address inequities. Thank you.
Thank you very much. Yes, I am still unmuted. And then, Dina, there's a question for you as well. Are the indicators that Uganda selected routine, such that a quarterly review can see new data points and trends analyzed on a quarterly basis? Or are you dependent on PMA surveys to see change, at least some of the indicators? Over to you, Dina.
Okay, thank you very much. So for some of the indicators, some of them are routine and others are program specific. So we kind of had a hybrid of both, so that the routine ones can still inform the routine family programming, but then the program for the specific, for the equity ones, we felt that it would help us more for advocacy. So it's a hybrid of indicators, both routine and and both routine and equity-specific ones to move the advocacy agenda forward. Thank you.
Thank you very much for that. There was one last question to Jill, and that was on the measurement as well. And let me just quickly get that one. Yeah, the effective monitoring considerations, I think Dina spoke a little bit about that, but specifically when you mentioned the information from clients should be collected and analyzed to determine if the care received was free from stigma, discrimination and bias on age, marital status, ethnicity, and other factors. What other factors do we have there, or can you? I guess that will be very context specific as well, but over to you, Jill.
Yeah, sorry, I guess I'm in the dark here. My sunlight has changed. So, but just to say that, yeah, I think it depends on what you're looking at and how you are, how you've identified your inequity in order to figure out how you should be analyzing it. So agreed, Petrus, it would be highly context specific, but you should keep that in mind. Keep in mind which particular characteristics you've identified and you're looking at.
Great, thank you so much. And then Dina, there's a follow-up question for you on were there any changes made in the DHIS to ensure routine data collection beyond Project Life for equity indicators? If not, how is this sustainable?
Come again, please.
Were there any changes made in the DHIS to ensure routine data collection beyond the Project Life for the equity indicators?
Like I have said, it's a hybrid of indicators, both routine in the DHIS and those that we felt would move the advocacy agenda to some level. So one, the DHIS wasn't changed to include the indicators. It's the indicators that we chose that would feed into what is already existing. So we are sure that the sustainability would be met because, again, we are still using the routine DHIS indicators. And those really outside the routine ones, we feel that they would really help us to kind of push through the agenda for advocacy and ensuring that they continuously feed into programming. I don't know if I answered it very well. Someone from the Ugandan team could kind of make more clarity.
I think you
this
made
is Frederick Makundi. I will quickly
please add.
So thank you very much. Yes, in addition to the issue that Dr. Dina raises, we know we have DHI, demographic health surveys every 5 years. And so the advocacy is ensuring that some of the key indicators could be included in those DHS surveys clearly. And also we've just launched the FP 2030 commitments for Uganda, as well as the CIP2, Cost Implementation Plan 2, and these issues are being built in there. And so we are going to make sure we promote the advocacy to have these included. But the health service.
Good, thank you very much for that additional information. So that brings us to the end of today's meeting. Once again, I would really like to thank all the presenters, but also the people who attended. And then just before we close, please remember that the presentation and the recording will be available on that link. Next slide, please. And then for more information, please be sure to visit the High Impact Practices website, where you have all the HIPs. And then there's also the link to the IBP network
and then the link to the research scalable solutions. Thank you so very much, and thank you also for the organizers. Have a great day, evening, afternoon. Goodbye.